I went to medical school in Alexandria, Egypt. That's on the Mediterranean Sea in Egypt, and did medical school there, internship there. Then I was fortunate enough to go to the Cleveland Clinic in Ohio. I was exposed to research and did there my license and board exams. Then I started to do my postgraduate education. That was in Winthrop University Hospital, one of NYU hospitals in Long Island in New York. I did my medical residency there. Then I went to Yale New Haven in Connecticut, did a chief resident year, and then went to the Mayo Clinic Foundation to do my cardiology fellowship training. That was a milestone in my education and career. Mayo Clinic is a great institution, and I did most of my cardiology training there. My final stop was at Vanderbilt in Nashville, Tennessee, when I did my interventional and structural cardiology training. Then I joined Willis Knighton. Many events happen to people and they kind of change their lives. I think the life-changing moment for me for choosing my specialty and further subspecialty in cardiology was my dad again dying of massive heart attack. I don't think anything could have helped him at that point with the circumstances there, but going forward, I wanted to help more people and to try to, as we go forward, to minimize the risk of heart attacks or the complications or consequences of heart diseases. That's why I love the cardiology, wanted to do everything I can. If I can go home every night and say, hey, Dad, I saved 2 of you today, maybe 1 of you today, that's very rewarding. That's why I'm doing cardiology. It was a weekend, I was on call, I had a patient, needed to go to the cath lab. He didn't meet the exact criteria to activate the cath lab, to have like the heart team come to the hospital and so on. But the right thing for the patient was to call the team in. So I call everybody and I keep apologizing for everybody. I'm so sorry, it's a weekend, I'm calling you to bring you in. And everybody was like, no, this is the patient's best interest, so we will do it. That really helped a lot. If you put the patient best interest as the only consideration in mind, things will be different and they will open up approaches. They will break rules needed to be broken. And then we will definitely help patients that are in bad need for help. I wonder if people have heard about new things that we can do in interventional and structural cardiology. It's not a bad thing to ask if you are the right patient for the right technology or the right procedure. Nowadays, people with atrial fibrillation, people with aortic valve stenosis, mitral valve disease, coronary artery disease, and other so many things in cardiology and cardiovascular diseases. If they have any questions, they should not hesitate to ask what's new in there and what can we do to offer and add some support or help to their needs. And we will help as much as we can. And I think the new technologies are just becoming more and more evolving to try to minimize the invasive procedures and try to take the patient safely to the right spot.